Let's begin with a real-world scenario. A 58-year-old man visits the dental clinic, concerned about a persistent sore spot on his tongue that hasn't healed for 2 months. He describes it as painful, located on the right side of his tongue. Notably, he has a long history of heavy tobacco use, smoking 2 packs a day for 30 years and drinks alcohol socially. Examination, the dentist finds a firm ulcerated lesion with irregular, raised borders and a slightly whitish erythematous center. The lesion feels hard and is fixed to the underlying tissue. Additionally, a firm non-tender lymph node is palpable under his jaw. These findings immediately raise suspicion for a serious underlying condition, especially given his risk factors. Faced with a chronic, non-healing oral ulcer in a patient with significant risk factors, clinicians must consider several possibilities. The leading concern is oral squamous cell carcinoma (OSCC), especially given the classic appearance and the patient's tobacco and alcohol use. Other considerations include a traumatic ulcer, which usually heals once the irritant is removed and lacks the firmness and rolled borders seen here. Syphilitic canker is another possibility, but it tends to be painless and would require serological testing for confirmation. Deep fungal infections like mucormycosis or histoplasmosis are rare and typically present differently, especially in immunocompromised patients. However, malignancy must always be ruled out first in such cases. Given the suspicious nature of the lesion, immediate action is essential. Any oral ulcer that persists beyond 2 weeks, especially in high-risk individuals, should be biopsied. In this case, an incisional biopsy is performed, removing a section of the lesion for laboratory analysis. Under the microscope, pathologists observe nests and cords of malignant squamous epithelial cells invading connective tissue, with features like pleomorphism, nuclear hyperchromatism, and keratin pearls, hallmarks of OSCC. With the diagnosis confirmed, the patient is referred for further imaging to assess the extent of disease and possible spread. Treatment typically involves surgery, radiation, and sometimes chemotherapy, with early detection being key to a better outcome. Oral squamous cell carcinoma accounts for about 90% of all head and neck cancers. Its prognosis depends heavily on the stage at diagnosis. Early localized tumors have a much better outlook than those that have spread. Major risk factors include chronic tobacco and alcohol use, and persistent exposure to UV radiation is a leading cause for cutaneous SCC. The primary method for confirming OSCC is a biopsy. Compared to basal cell carcinoma, squamous cell carcinoma grows faster and is more likely to metastasize. This case underscores the importance of regular oral cancer screenings and prompt evaluation of any suspicious oral lesions, especially in high-risk individuals.